There's a lot of slides, and for the sake of the time, although I'm the last speaker, hopefully I will have enough time to wrap it up. We'll try to fast forward. If you guys have questions, please do me a favor and ask me, interrupt me if you need to. So the subject or the title of the discussion was basically surrogate markers for survival. As a clinician, I'm interested to see what we can do differently for patients with cancer, especially in advanced stages, that can increase their survival, improve their quality of life, and improve their survival in general. So we have chemotherapy agents, targeted therapies, all these new technologies that are coming out intending to improve patient survival. However, as you have heard all through the last 3 days of the conference, the technologies improve and our understandings of the cancer biology improves. However, does that translate to a better outcome in the clinic? Generally, no. And my intention here is actually open your eyes to something completely different than what you have heard so far, which is how we can actually look at the biology of the cancer and correlate that with appropriate tools to improve patient survival directly and most efficiently. So instead of spending millions of dollars on coming up with new targets, how can we use the available tools, the available targets, and we can take advantage of what we have to improve patient survival very quickly. So I call it biologic translational tools to predict clinical outcome in advanced cancer. So we have 2 abstracts here. It's a lot of information, but what I want you to get out of this conference and my talk is this. We're going to talk about case series that I have treated in my clinic using a new protocol called multi-targeted epigenetic therapy. This protocol is not available anywhere else. I'm the inventor of the treatment. It includes a variety of the treatments, and as I said, this is in the early stages of the development of this protocol. And also the slides will contain a lot of proprietary information as far as what we do to monitor these patients and what we have found to be the most efficient to translate their outcome. So we're going to talk about prognostic surrogate markers of survival. Majority of the markers that we are interested in our clinic to check and monitor has to do with intratumoral hypoxia. So you heard a lot of things during this seminar about tumor heterogeneity. We have that in the literature that tumor heterogeneity is related to intratumoral hypoxia. The tumors that are more hypoxic, they show more variability in their signature markers. So we're going to talk about that. We're going to talk about how hypoxia can also drive angiogenesis and how this protocol was designed to go after these hypoxia-driven pathways. So at one shot, we can control angiogenesis. At the same time, we can control the tumor heterogeneity and dissemination of circulating tumor cells into the system. So if you think that circulating tumor cells are driven by hypoxia through many known pathways, instead of killing and destroying the circulating tumor cells by a variety of the methods that are currently under the investigation, I'm sure you've heard of the SO500 trial that failed on transition of the first line to the second line of therapy in breast cancer using circulating tumor cell analysis as a marker. Now we know that instead of going after the circulating tumor cells with different killing methods, cytotoxic therapies, we can actually prevent them from dissemination into the bloodstream by going after the hypoxia. So we're going to talk about that. This protocol, as I said, is not tried anywhere else besides my clinic. As a clinician and scientist, I would be happy to address all questions about that. But just keep this in mind. The rationale of the talk is this. We're going to change the entire concept. We're going to redefine what we're looking in cancer. We're going to look at what is causing entire biology to be disrupted. Circulating tumor cell dissemination, angiogenesis, and heterogeneity at the same time. I'm going to target it. So you can read these slides. They're very clear. We talk about the different laboratory markers that we have failed to correlate with patient survival. Current standard of care is as such that if a patient goes to the clinic and gets treated with any sort of therapy, we as clinicians we look at the RECIST criteria. RECIST criteria measures the greatest diameter of the tumor at the largest site, and then we define if the patient has responded to the treatment or not. That is not correlating with the patient's survival in the majority of the time. That just tells you that what we are measuring as clinicians in patient defining response is not the best way to define response, because patient can have a better progression-free survival and at the same time have low overall survival. So what we need to do is to have better tools to correlate with patient survival. So there are 3 markers that in my protocol I look after and use them as a companion diagnostic tool for my method. One is circulating tumor cells. We do quantitatively and qualitatively, so we look at the number of circulating tumor cells through the cell search for breast, colon, and prostate cancer that is approved. And then we look at other types of tumor that we treat through other laboratories outside the US that look at these circulating tumor cells. They do an mRNA expression as well as a DNA point mutations as well as protein expressions. So we get a full signature of these circulating tumor cells. And then we treat these patients. After 2 weeks of treatment, we redo the same test. So we analyze the circulating tumor cells by number and by quantitative measures of the markers. And we see 100% so far success in completely or majority of the time, almost 100% eradicating these circulating tumor cells. As a cases I'll present in the next few slides, you'll see that these patients come with very high aggressive disease that has failed majority of first and second line chemotherapies. They come as the last resort. When we start them on the treatment, before we start, we look at the circulating tumor cell number. Some of them have beyond measurable numbers in 7.5 cc of the cell search. And then after 2 weeks of treatment, we repeat the same test. And I can show you these cases, but it's just mind-blowing how you can bring down the number and basically the EMT transition, that's what we're interested in, of these circulating tumor cells, and basically crushing these mesenchymal featured clusters or emboli of the CTC and reducing the metastasis tendency. So when you reduce the tendency of metastasis in this stage 4 disease, you prove that by doing another PET scan. We don't do the CT in any of our patients. The last CT I ordered was probably 2 years ago. We order PET scan in these patients because we're interested to see what's the metabolic activity of these tumors in the PET scan. Why? Because also metabolic activity of the tumor correlates with intratumoral hypoxia. Hypoxia response elements are driven through the HIF and indicate how this metabolic machinery inside this tumor is acting. And if you can bring that down, bring the SUV activity of the same tumor, and reduce the angiogenesis, which we measure through mRNA VEGF to the serum or plasma, or serum plasma VEGF itself, then you have tools that correlates to the patient's survival. So angiogenesis has been reduced, circulating tumor cell analysis shows improvement, and you have reduced metabolic activity in the PET scan. These 3 together will show, as I will show you in the cases, how these patients will do in long term. You know, I was at the 16th Symposium of International Symposium on Angiogenic Therapies, sponsored by MD Anderson Cancer Center, which by case happens to be the laboratory that we work with very closely at MD Anderson Cancer Center. And the data was clearly disappointing. Why do these anti-angiogenic drugs don't work? The reason that they don't work is exactly the same thing that I mentioned. They block the VEGF through the feedback loops, the HIF gets overexpressed. And we know that, and that's why current clinical trials are focused on experimental anti-HIF therapies combined with other anti-VEGF drugs, because every time you use VEGF, and then there are so many other problems, because it's not about the VEGF itself. It's about affinity of VEGF to bind to its VEGF2 receptor. And that affinity has nothing to do with how much VEGF you have in the system. And that affinity has to do with the microenvironment structure that is stimulated by HIF-driven factors. So HIF produces driven factors that go to the bone marrow, and in the bone marrow drive cells come to the microenvironment, and they have matrix metalloproteinase 9 enzyme that cleaves the VEGF and makes it attached to VEGF2 receptor. So the stimulation of the VEGF2 receptor is made by microenvironmental stimulation and involvement of the bone marrow-derived cells through hypoxia in the response elements and HIF. So if you don't address the HIF, if you don't address the c-Met and heat shock proteins that are upstreams for the HIF, blocking VEGF is not going to benefit the patient. That's why you see overall survival does not change for patients who receive VEGF. Majority of the clinical trials have failed. You know, hypoxia is the driver for tumor growth as a common signature of highly malignant tumors with capacity to metabolize glucose quickly to lactic acid. This is the Warburg effect that has been already described. Excuse me. In the literature, hypoxia stimulates the hexokinase activity. So just looking at this metabolic machinery, as I called it, in the cancer cells, especially when you're talking about cancers that have more metabolic activity, more fueled, you may call it a turbo-fueled engine. This happens when you use chemotherapy very often. And you'll see in one of my slides, the more the patient receives chemotherapy, standard cytotoxic therapies, the more the tumor develops hexokinase activities through hypoxia response elements. It's very obvious. There are only a few agents, as far as I know, in whole traditional chemotherapy classes that don't do that. The rest of them, you know, we talked about breast cancer. What is the standard of care for breast cancer? First line of therapy is using cytoxin. Cytoxin is notorious to increase the hypoxia inside the tumor. So you should not be surprised at the clinic when you treat a patient who has a very localized disease with traditional chemotherapy, first line of therapy. Next thing you know is that the patient comes back with bone mets and liver mets and lung mets. We see that all the time. Why does this happen? It's not because the cancer was having a tendency to spread. Some people with breast cancer, uterine cancer, ovarian cancer, they have it for 5-6 years and it doesn't even spread. As soon as you treat them with neoadjuvant therapy, in fact, I had this discussion with circulating tumor cell panel, we talked about this neoadjuvant chemotherapy should come out of the standard of care protocols, because when you use neoadjuvant chemotherapies, you have a mass of the tumor, you can easily disseminate, leak these circulating tumor cells into the system by using chemotherapy itself. Chemotherapy increases the adherences of the circulating tumor cells so they can detach and attach. And that does not happen unless you use chemotherapy. Versus if you do adjuvant chemotherapy, you have removed that tumor, you don't have that risk of dissemination. And I see that all the time in my patients. They do neoadjuvant chemotherapy, everybody's happy, oncologist is clapping hands. 2 months later, patient has bone mets. Why? Because we created that by our therapy, because we did not address what translates to the patient's survival. The size of the tumor, I always give this example to my patients. A tumor this size and a tumor this size, which one is worse? And I always get this answer, the bigger the worse. That's out of reason and logic, because the tumor tendency to spread has nothing to do with the size. The tumor size, the smaller it is, it may have more vessels and a tendency to spread. So killing all these passenger cells where the drivers are left behind is not going to help the patient in the long run. The tumor is going to metastasize when it's smaller and it has more vessels. Again, hypoxia increases angiogenesis. We already know that. The other thing that I was interested when I found this literature was that circulatory tumor cells, when they are disseminated, they also can produce new vessels. A very damaged, structured vasculature around the tumor that is created by these circulatory tumor cells. It's like a vicious cycle. You produce circulatory tumor cells, but you provide increased angiogenesis. And then circulatory tumor cells produce new vessels themselves. So you have a vicious cycle of circulatory tumor cell improved, increased, and then you have more vessels, and then you have more CTC, and then you have more vessels. Something has to break this vicious cycle. And certainly none of the treatments that we use so far is able to do that. So far, we don't have any treatment that is HIF blocker. Even if they come up with the HIF blockers, Every time you block one of these molecules, you have feedback loops. You block the mTOR, PI3K goes up. You block the VEGF, HIF goes up. You really have to have a multi-targeted therapy, and that's the protocol that I came up with. You have to have a multi-targeted therapy, vertically and horizontally. So you have a plural potential targets. So every time you have these targets across the board, you have 200 targets that you're targeting at one time. Heterogeneity and hypoxia, we talked about that. Chemotherapy increases angiogenesis, I talked about that. Conclusion, I guess we got enough points crossed. This is a protocol, multi-targeted epigenetic therapy. The reason that we called it MTET was because epigenetic targets were first described by us to be the targets of this treatment. And then later on we found that it's not, well, you know, epigenetics obviously is involved in everything. And that's why now we know that if you use cytotoxic therapies, you have to do epigenetic therapies along the way. If you use angiogenic blockers, you have to do epigenetic. Because think about renal cell carcinoma. You already know about the VHL mutation and the role of VHL in expression of the HIF. So you have HIF that is ubiquinated, that's an epigenetic modification by VHL. And you have a mutation in VHL where you have a hypermethylated VHL, the ubiquitination of the hypoxia-induced factor 1 is not going to happen. And that's why you see renal cell carcinoma has such a tendency to recur and metastasize, because we're not addressing this. So we call it epigenetic because part of what we need to do to block angiogenesis is through epigenetic therapy. I don't think I have time to go over the second abstract, but if you guys have any questions about the second abstract, maybe you have access to my slides after this presentation, feel free to call or email me. Let me give you my website, my phone number, and my email because I have run out of the cards. My website is very simple, allcancercare.com, allcancercare.com. When you go to the website, you see all these work that I have done, all these advisory work, the testimonials, all that. But it's interesting to look at these figures, and I have some of them to show you. Okay, so case review. So I have 100 patients that I have, 105 patients that I have treated with stage 4 disease through this method only. And these 105 patients, they have responded measures by these markers that all correlated with survival. I don't care if a patient CT scan shows better response, progression. I want the patient to live longer with no toxicity. And that's what my protocol does. Minimum toxicity improves survival. So among these 105 patients, I will briefly, for the sake of time, I will present a couple of them to you so you can see what I'm talking about on images. So these patients basically, majority of them, over 60% of these patients had stage 4, had failed standard treatments. So they were pretty close to be called for hospice. No options available except palliative treatment. And then there were these results. Look at these results. Imaging responses, decreased metabolic activity. 58 patients had imaging reports to follow for their condition. The other 42 had no imaging or it was not applicable or relevant. Out of 58 patients, 36 patients, 62% had positive response on imaging. 62% of a group of people who 64 out of 100 had stage 4 disease. No treatment available for them. And then it goes to VEGF, FGF to IL-8. 37 patients had increased vascular endothelial growth factor. And out of these patients, 34 out of 37 had decreased VEGF. It's almost 100%. It's almost 100%. I did a chart review and I barely could find 1 or 2 patients that did not respond. Everybody else, we were able to either completely normalize their VEGF or bring it down substantially. And then circulating tumor cells, that also is almost 100%. There was only one patient who got worse. Obviously, this data reveals superior response in a group of patients to what we expect from a stage 4 disease patient, and obviously superior to the standard care chemotherapies, targeted therapies, angiogenic blockers, you name it. There's not a single method, protocol, treatment that I'm aware of as a clinician, and we have talked with NCI. They're extremely excited about what we're doing. We've talked with major university-based institutions, oncology labs, that we basically pay them to run the labs for us. And they call me every day and they tell me they've never, we use a lab in Canada. The director of the lab called me and he said he has never seen these in his laboratory studying any chemotherapy. And this is a lab that the FDA in Canada uses to approve drugs. And we looked at the morphology, the apoptosis markers, the integrity of the spheroids in the three-dimensional cell culture media, and we were able to show significant response. In one, I don't have the slide here, but in one case, breast cancer cell line, we examined that, exposed it to cytotoxic therapies, first line of therapy, and we combined it with our protocol agents, and what we found was that there was 10-fold improved response in apoptosis. So these are some of the cases. 29-year-old girl, she was a medical student actually when I saw her. She had stage 4 malignant melanoma, failed all standard treatments, immune therapies, Yervoy. She went to Germany, did immunophoresis with TNF inhibitors, all that. She had progressive disease, extremely progressive. You can read the slide and see how she responded to our therapy. Her father was working at FDA, and they came to me because they knew that FDA has not approved any drugs that she could benefit from further. And she had a massive tumor burden. We started to treat her only by our therapy. And these are the results we got. The tumor burden decreased substantially. We actually normalized the lipid associated sialic acid, which is the marker of the tumor burden in melanoma. First day I saw that. And if you look at the first one, you see that there is positive telomerase, indicating that they could identify the secondary tumor cells. On the second one, you see it's negative, 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 complete eradication of the secondary tumor cells. If I see a patient that doesn't show something like this with my treatment, I was surprised. Because as I said, the success in eradicating the secondary tumor cells is almost 100%. Case number 2, 67-year-old with renal mass. He was diagnosed with renal cell carcinoma. Decided to be recruited in our treatment protocol. We treated him, as I just mentioned. Renal cell carcinoma is notorious to be epigenetically and angiogenically driven, and so we were able to do a secondary tumor cell analysis before and after the treatment. Finally, he did the surgery and removed the tumor. As you can see, I have all this information. If you read, you have all these markers. As I said, when the tumor regresses, probably you see the tumor markers coming down, you see the scan, all those things, but we're not that much interested in it. I mean, if you look at that mainstream oncologists, what they would be interested in is to see if the tumor markers are good. Tumor markers are not prognostic. So we check them just to tell, yeah, it's coming down. But that's not really an indication of response. So before and after, against secondary tumor cells, you can see that there was positive G250, which is a marker for secondary tumor cells from the renal cell. And then after, look at the dates, 14/8 and 2/10. And then you see that everything is negative except the telomerase. Now, why do we have the telomerase positive after the surgery? Because, just like I said, every time you do the surgery, and that's why we have a protocol for a patient who does resect the tumor, they have to come and get the treatment again. Because every time you remove the tumor, you will leak these secondary tumor cells into the system. But interestingly, these cells were not showing the G250, which is the marker for aggressive renal cell carcinoma. Sample 3 is a 64-year-old with pancreatic cancer. And this guy is a very interesting, still is, obviously all these patients are still alive, except the one that I mentioned. This guy had a very large tumor in the pancreatic head, thick head, and was unresectable. Basically, he came to us, we started the treatment. This was the decision that we made about him. We said, I know that my treatment is going to work independently. Now it's up to you if you want to do Gemzar-Abraxane regimen. And he decided to do our therapy alone first, and then start Gemzar-Abraxane if he wants to. We said, fine. We have an oncologist that works in our board, is head of the research funded by Mayo Clinic in Central California. He has 29 oncologists doing research under him. And he said, fine. And we did that. And just by our therapy, we were able to normalize CA19-9. His CA19-9 dropped 80% just by our therapy. We did circulating tumor cell analysis, as you can see, complete eradication of CTC just by our therapy. For the sake of time, I just want to show you some of the scans. So, breast cancer, there's a lot of information there. As I said, if you are interested, I can give you the slides, but drastic response. The more heterogeneous the tumor is, like lung cancer, breast cancer, the more hypoxically driven, the more the response to our therapy. Look at these. This is pre and post. This patient did not receive any chemotherapy. Stage 4 breast cancer, pre and post. Do you see anything post? No metabolic activity. Those are highly metabolic activity, high lymphadenopathy in the mediastinum before treatment. Look at this. They are shining like the sun. SUV activity probably around 16, 17. Completely gone. This one, breast cancer again, had failed all conventional treatments, had failed 6 regimens of chemotherapy, has chest involvement, lung metastases, bone involvement, pleural effusion. She was drained 2.7 liters of fluid every week from her pleural space, malignant fluid, and she couldn't breathe. She comes to my clinic, we start her treatment. In a matter of just 1 month, the pleural effusion completely goes away. To the point that we did a cytology on the pleural fluid from thoracentesis, and it was negative for malignant cells. Look at the images. When Jeff responds, secret tumor cell analysis at one point dropped to 0 until she decides to go to Dallas. She comes back, it's 4, drops again. Look at the image. This tumor, as you can see, has occupied the entire 4 quadrants of the breast. It's like the entire breast is occupied by the tumor. There's nothing left. And if you look at the bottom picture, this one, you see, this is the pleural fluid. This is the fluid that is in the pleural space, drained, as I said, 2.7 liters every week. Look at the post-treatment. There's no fluid. The tumor in the breast still exists, but look at the metabolic activity. None. You don't see any differences between the metabolic activity from the post-treatment and the background. And she did not receive any single treatment except mine. Again, look at this. Have you ever seen this? As a clinician, I have never seen a stage 4 cancer with this mass that just shuts down with any treatment. Again, this one was a breast cancer. Interestingly, had brain mets, bone mets, you name it, distant organs, and then finally, after going to Cancer Treatment Centers of America, getting no results, trying any sort of therapy you can name it, finally she ends up with me. I don't have a lot of time, so I'm just going to show you what I found after the treatment in her. All the markers came down. Look at the secreted tumor cell, 1,000. And post-therapy is 1. That is actually 0 as we speak. She had no secreted tumor cells after my treatment with Jeff normalized from 150 down to 24. All markers, scan, everything in there. Conclusion. Summarizing our data, we present a new novel therapy that aims to eradicate the detected disseminated tumor cells, especially modify the quantity and the composition of genomic instabilities or imbalances, which we were able to correlate to the actual clinical outcome of the patient.
Just I one question. I mean, these are very intriguing and case reports, and but some people might wonder, it's probably N=1 N=. So I just wonder whether you can put one study, and then like if you can, like a post-clinical study setting. So
that's why I'm here, actually. I'm here to, as you know, doing the clinical studies in phase 1 and 2, which we are proposing, takes money. And we are interested to have partners who have experience in this field, so what we have can be taken to the next level. But that's what we want to do, that's what we're aiming to do, to prove. Obviously, we have the proof of concept. We actually want to show that in the patients, in randomized controlled trial, although there are questions about stage 4 patients who have failed other treatments, it would be ethical to put them in a randomized controlled trial because there's no other options for them. Obviously, they're going to die if they receive placebo. And so the first question is it ethical, even when you go to the FDA, which we're trying to do, is it ethical to put these patients with these results on nothing? Or because what we did here was that we used a historical response. So they had no response to first and second line of therapy, third line of therapy, sixth line of therapy. So pretty much there was not anything left for them. So is it ethical to just do nothing and call hospice for them as a control? I don't think that makes any sense with these results to have a control study. But doing a phase 1-2 study and proving it through the standard controlled environment, I think is the next step.
Thank you to all speakers again.